This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. He's a 75-year-old gentleman who has this lens-induced glaucoma. It's a phacolytic glaucoma with a Morgagnian cataract. We have a small free-floating nucleus inside the capsular bag, which is seen in these slit lamp images. Along with that, he has pseudoexfoliation, moderately dilating pupil, and the situation is complex. The patient was treated with anti-glaucoma medications and topical steroids to control the inflammation, and today the pressure is around 24, and I'll be operating after giving IV mannitol and a perivulvar block with massage, which will bring down the pressure significantly. Now, patient has a pre-existing astigmatism of 1.2 diopters at 180 degrees, and that's the reason why we also have planned a toric lens, but I'm not sure whether the conditions intraoperatively would allow me to go ahead and do it. So the challenges are multiple. Number one, we have a pseudoexfoliation and a moderately dilating pupil, but the bigger challenge is the health of the zonules. In these long-standing hypermature cataracts, we expect a very weak zonules, something like a diffuse or global zonulopathy, and rhexis is going to be a challenge. Needless to say, the free-floating nucleus adds on to the problem. So with these complexities in mind, I am going ahead with a scleral incision in this patient. The idea being, if the need arises or the situation gets more complicated, I would have to abandon phacoemulsification and maybe remove the nucleus manually, or in the worst case scenario, wherein I would be unsuccessful in saving the bag and it turns out to be an intracapsular extraction, then I could enlarge the same scleral incision to put in the rigid iris claw lens. So that's the idea behind going in with the scleral incision. So I begin by making two side port incisions. The anticapsule is stained with trypan blue under the air bubble. Viscoelastic placed inside the eye. Time to create the main incision. So the globe is stabilized and a transconjunctival scleral incision is created about 1.5 mm from the limbus. And then using a 2.8 mm blade, a sclerocorneal tunnel is created before puncturing the descendants to enter into the antechamber. So we have about 1.5 mm in the sclera and another 1.5 mm in the cornea. This is the length of the sclerocorneal tunnel before we enter into the antechamber. So this would give a reasonable amount of self-sealing nature, and in the worst case scenario, if you want to extend, the same scleral incision can be extended on either side and the sclerocorneal tunnel extended to fashion a self-sealing incision even when we want to extend. The rhexis is the most critical step of the surgery, and the moment I touch the capsule, as expected, the liquefied cortex just flows out. So to increase visibility, I need to gently irrigate out the liquefied cortex. It's important that we are not too harsh or aggressive at this stage. Excessive irrigation can extend the rhexis towards the equator. So gently tapping and gentle irrigation would ensure that the liquefied cortex flows out. Now is the time to continue with the rhexis. Viscoelastic is placed opposite to the area where the capsule is opened, and this is critical. We don't want the viscoelastic to go inside the bag. So I go in with my forceps, and as I'm trying to complete the rhexis, let me freeze the frame here. You can see the wrinkles at the edge of the capsular tear. Now this is suggestive of extensive zonular weakness. So this eye definitely requires a CTR. Now, should I continue to do the rhexis or stop and implant the CTR now itself? That was a thought which was going in my head at that point. So I somehow continued, and with some difficulty, I could complete a rhexis. And obviously, this rhexis is too small to continue with any procedure. But the good thing is, because we have an intact rhexis, I can go in and put in the CTR now. This is going to stabilize the bag, and then I can enlarge the rhexis. So this is what is my plan now. The bag is inflated with OVD, and then the CTR is gently navigated into the bag. And please keep a close watch on my left hand as the CTR is being navigated inside. The CTR has to be compressed and held so that we don't induce any traction to the capsular bag as the CTR is being navigated. So once the CTR is in the bag, it acts like an artificial zonules and can give us reasonable strength to continue with the rhexis creation. Now a tangential cut is given with the micro scissors, the flap is held with the forceps, and the rhexis is enlarged. It is still not big enough, but Let me see how things turn out. Now is the time to perform the nucleus management, and it is the most critical aspect here. Although the nucleus is small, thin, but reasonably dense, and I need to divide the nucleus into two halves. A small central groove is created so that I can bury my tip deep inside, but I'm finding it extremely challenging to grip the nucleus because the nucleus is just free and mobile. So as I'm holding the nucleus and trying to do the chop maneuver, I feel that it is out of control, and because there is no posterior support, it looks like the nucleus is moving down, and it doesn't look to be very safe at all. Now, how do we go about from here? So my strategy is to pull the nucleus out of the bag and maybe do a supracapsular emulsification. That would be much more easier, less stressful in the bag. But the challenge here is it might be difficult for me to maneuver the nucleus out of the bag with this small rhexis. I need to enlarge the rhexis again. Irrespective whether I would like to convert to MSICS or Phaco in the supracapsular space, I need to enlarge rhexis. The micro scissors and the forceps again come into play. A tangential nick is given and the forceps holds the flap, and then the rhexis is enlarged. Now the rhexis is of decent size. I need to maneuver the nucleus out of the bag. With two Sinskey hooks, the nucleus is gently maneuvered out into the bag. Looking at the size of the nucleus, I was in a dilemma. Should I enlarge the incision and pull it out of the eye manually, or should I attempt Phaco emulsification? Now, because the nucleus was thin and soft, I thought I would continue with Phaco emulsification, of course under the cover of copious amount of dispersive OVD under the endothelium. At this stage, a second thought also occurred to me, that should I consider an IOL scaffold in this place, because the bag would come out. Since the CTR was adequately supporting the bag, I thought the bag is reasonably safe and my Phaco tip is far away from the bag. So I did not think that the IOL scaffold was a necessary technique at this stage. But dealing with the nucleus has to be very gentle. My primary concern is the corneal endothelial injury. Slowly but surely the nucleus is chopped down into two fragments, and then with the chopper I'm trying to push it back under the pupil, and only a small part of the nucleus is above the pupil in the antechamber, and then the emulsification process is being continued. The left hand instrument is always on top of the fragment to guard it against hitting the endothelium. Slowly but surely the entire nucleus piece is emulsified. So now is the time to implant the lens. The next question, should I go in with the planned toric lens or should I use a multi-piece lens and an IOL trap technique? Now, because the zonular health was not so great, I was not sure whether in the bag lens would hold the bag for a longer duration of time. So in this situation, I aborted the idea of the toric lens, and instead I'm using a 3-piece hydrophobic lens, placing the haptics in the sulcus and then optic behind the rhexis margin in the bag to achieve the IOL trap technique. The haptics are negotiated in the sulcus. The OVD both in front and behind the lens are aspirated out. The optic is now gently pushed back into the bag. The ovalization of the rhexis confirms that the optic capture is good enough, and this lens is going to be secure for a long duration of time. Now, regarding the residual 1.25 diopters of against astigmatism, well, the long-term stability of the lens is much more important than treating the astigmatism. That's what I thought at that moment. Viscoelastic is removed from the antechamber and near the angle. These patients are vulnerable for next day IOP spikes, so we need to monitor them appropriately. The side ports and the main incisions are hydrated. That's the case is done. Now, these are the first day post-op pictures. There's corneal edema. The pressure is still high. It's around 28. The patient is continued with anti-glaucoma medications for a couple of weeks. And this is the next follow-up, and the cornea is relatively better. The patient has got a reasonably good improvement in visual function, and the patient is happy. And these are the subsequent photographs. So to summarize, the key takeaway from this case was saving the bag was very critical. For that, timely insertion of the CTR was mandatory. So I couldn't get a full-sized rhexis in the first go. So important to create a small rhexis first, put in a CTR to stabilize the bag, and then enlarge the rhexis, create a larger rhexis. Because nucleus management was difficult in the bag, I prolapsed the nucleus out in the antechamber. And of course, an easier option would always be to just convert it into MSICS and remove the nucleus in mass. But in this case, I decided to go ahead with phacoemulsification to remove the nucleus. Well, either options would have been alright. And that was it. Thank you for watching and hope you found this helpful.